the new pouch in place, fitting the opening carefully over the stoma. She adds deodorant to the pouch as prescribed and then applies the appliance closure device. After replacing the ostomy appliance, you'll remove your gloves and dispose of them and any other materials in the proper receptacle. Make sure the client is comfortable, then wash your hands. Document the condition of the stoma and the peristomal skin, the skin and the stoma care you provided, the appliance change, how the client tolerated the procedure, and any other concerns or observations in the client's record. It is important that the client and any caregivers become proficient and comfortable with replacing the appliance prior to discharge. You'll explain each step as you empty the pouch, provide stoma and skin care, and replace the pouch. All the while, you'll encourage the client and caregivers to help. When they are ready, you'll observe a return demonstration to ensure proper care after discharge. A nasogastric or NG tube is a flexible tube with a hollow lumen that is inserted through one nostril, down the nasopharynx and esophagus, and into the stomach. NG tubes are inserted for a variety of reasons: to administer enteral feedings or medications to clients who have difficulty swallowing, to lavage or wash the stomach, such as after an ingestion of poison or an overdose of oral medication, to obtain a specimen of gastric contents for laboratory analysis, or to suction stomach contents to prevent or relieve gastric distension, nausea, and vomiting. Before inserting an NG tube, you'll assess the client for patency of the nares to be used for insertion, intact nasal tissues, any history of nasal surgery that might interfere with safe insertion of the tube, the presence of a gag reflex, and the ability to cooperate with NG tube insertion. You must also determine the type of the tube and the size of the tube you'll insert, and whether or not you'll attach the tube to a source of suction. You'll check the physician's order for this information, as well as the institution's protocol for the insertion procedure. Generally, the single lumen Levin tube is used for lavage. The double lumen Salem sump tube is used for lavage and gastric suctioning, and a silicone or polyurethane tube is used for longer-term placement for tube feedings. Before you begin the procedure, explain it to the client and evaluate his ability to cooperate with you as you insert the NG tube. Have assistance available as needed. Now let's go ahead and demonstrate inserting an NG tube for an adult client. We'll assume the nurse has checked the provider's orders, verified the client's identity, explained the procedure to the client, and reviewed the institution's protocols for this procedure. The nurse assembles her equipment. She will need clean gloves, a cup of ice or water and a straw, a towel, facial tissues, a flashlight or pen light, the NG tube, a basin of warm water to soften a plastic tube, or a basin of ice if a rubber tube is used, water-soluble lubricant, a tongue blade, a 50 milliliter syringe with a tip that fits the tube, a stethoscope, a pad or towel to protect clothing and bedding, a clamp or plug, a pH strip, paper tape, a rubber band, and a safety pin. The nurse washes her hands, then places the client in a high Fowler's position with a pillow behind his shoulders. She provides privacy and places a towel across the client's chest. Using the flashlight, she double-checks the client's nares for patency. Next, she determines the length of the tube to be inserted, measuring from the tip of the client's nose to his earlobe and down to the xiphoid process. This is about the same as the distance from the nares to the stomach. She marks this point on the tube with tape. Next, she puts on the gloves and lubricates the first 4 inches of the tube. She makes sure the cup of water and the facial tissues are within the client's reach. Gently, she inserts the tube through the nares, asking the client to hyperextend his neck to reduce the curvature of the nasopharyngeal junction. She advances it toward the nasopharynx, directing the tip along the floor of the nares and toward the ear on that side. It sometimes takes slight pressure to pass the tube into the nasopharynx, and at this point the client's eyes might water and he might need the tissues. As the tube reaches the oropharynx, he is likely to gag. It is helpful to have him tilt his head forward and drink some water. If he continues to gag and the tube does not advance, it might be coiled in the throat. She would check for this using the tongue blade and a light source, and if it is coiled, she would withdraw the tube until it is straight, and then re-advance it. The nurse continues to advance the tube up to the tape mark on the tube. Had she observed any change in the client's respiratory status, the loss of his ability to speak or uncontrollable coughing, She would have removed the tube immediately and tried again, as it might have advanced into the lungs. Then she aspirates the stomach with a syringe and checks the pH. Stomach contents are normally acidic, usually with a pH from 1 to 4, although it can be as high as 6 if the client is taking certain medications. Tube placement will be absolutely confirmed later by X-ray. Finally, she secures the tube to the bridge of the client's nose with tape and pins the tube to the client's gown at the chest, using a rubber band and a safety pin. After inserting the NG tube, you'll remove your gloves and dispose of them and other materials in the proper receptacle. Make sure the client is comfortable, then wash your hands. Document the insertion and placement. Check how the client tolerated the procedure and any other concerns or observations in the client's record. On an ongoing basis, you'll assess for signs of complications such as improper placement, dehydration, electrolyte imbalance, enteritis, aspiration, nasal erosion, and gastric distension. You'll also provide frequent oral care. You'll clean the nares and apply a lubricant to prevent erosion. You'll also change the tape over the nose as needed and document these interventions in the client's record. Before removing an NG tube, you'll check the provider's order, assess the client for bowel sounds, and check for the presence of nausea or vomiting when the tube is clamped. Now let's observe the nurse removing the client's NG tube after explaining the procedure to the client. The nurse assembles her equipment. She will need a pad or towel, facial tissues, clean gloves, a large syringe with a tip that fits the tube, and a plastic bag for disposal. The nurse washes her hands, then provides privacy, places a pad or towel across the client's chest, and gives him tissues to clean his mouth and nose after the tube is removed. She detaches the tube from any suction or feeding apparatus and clamps or plugs the distal end of the NG tube. Next, she unpins the tube from the client's gown and removes the tape securing the tube to the client's nose. She unplugs the end of the tube and instills 50 milliliters of air into the tube to clear it of any contents. She asks the client to take a deep breath and hold it to keep the glottis closed, thus preventing aspiration of gastric contents. She pinches the tube and, with a quick, smooth motion, withdraws the tube and places it in the disposal bag. After removing the NG tube, you'll remove your gloves and dispose of them and all materials in the proper receptacle. Help the client clean his nose and mouth if needed. Provide oral hygiene. Make sure he is comfortable, then wash your hands. Document the tube removal, how the client tolerated the procedure, and any other concerns or observations in the client's record. An NG tube helps provide nutrition and comfort to compromised clients. Proper placement is essential and must always be verified prior to using it to administer medications or feedings. An NG tube can be uncomfortable for the client, but your good oral and nasal care will help reduce that discomfort. And securing the tube properly to the client's nose and to the gown will decrease the risk of dislodgement. Endotracheal suctioning involves the removal of sections by means of passing a catheter into the endotracheal tube. Before suctioning, determine if your institution requires an order. If so, obtain one. If a standard protocol for endotracheal suctioning is in place for intubated clients, be sure to adhere to your institution's policy when implementing the procedure. Clients with an endotracheal tube require suctioning when there are visible secretions in the airway or if the client is coughing or breathing against the ventilator. Other indications for the need to suction can include a transient increase in peak airway pressure, a decrease in tidal volume, or even a decrease in oxygenation, as noted by decreased SaO2. The nurse would suspect airway obstruction due to the presence of secretions or a mucus plug if the breath sounds are diminished or chest rises less than expected.